It was very excellent talk by all the three speakers. They covered their subject very in depth and completely. However, there are many questions in this subject which are controversial and required to be discussed. And we have few questions from the audience, and I would like to ask, all the three speakers are with me?
I'm there, Doctor.
Yes.
I can't start my video.
Okay. So the first question is that if the natural cycle, this is I think for Sarah, if the natural cycle is the way to go about, how do you avoid weekends? Because you have to monitor the cycle during weekends and do transfers during weekends also.
Yeah, thank you very much. That's a great question. Well, I actually remember very well, there was a patient who was a flight attendant at the time when there were still flights everywhere. That was a few years ago. So she had a very spontaneous ovulation, very regular cycle, and she has the misfortune that her ovulation was always falling on the wrong day of the week. So there was never a synchronized, possible synchrony with the embryo, so that she would be at the same time in Helsinki and in a receptive day for the embryo. So basically, I mean, there was a lot of energy went into this because she tried for a few cycles and that was never correct. So basically, if you happen to have a patient like this, also it's difficult when patients travel in and out of town. But what you could try, of course, is the oral contraceptive pill. So with this, you can try to, I mean, if it is good if you know how soon the patient's spontaneous ovulation will resume after stopping the pills, that's one way. The other one, of course, you can do the pre-treatment with some kind of a progesterone type, like a gestogen, to induce the periods. And then you just really hope that the ovulation falls on the right day, because normal nature is something that even the doctor cannot tame completely. It is still nature.
Is the second question. The second question to you is, how do you, what is the best way to monitor the natural cycle? How do you monitor? With ultrasound, with LH surge? How do you monitor? That is the second question.
Yeah, thank you. Well, that's another very good question. I think you can monitor a natural cycle with a spontaneous ovulation in many different ways. The way it is done in Finland, it avoids the patient coming many times during the cycle to the clinic, because everybody is busy, everybody has the right to their own life.
What is the best lab way to find out which is the cutoff value for LH surge? That is the question asked to me.
Cutoff value for LH surge. I mean, the level which they say is anything above 10 milli-international units is enough to tell you that the LH surge is imminent. So in short, once you have a level coming to 10 plus, that's the time you should expect that the LH surge will start coming in now. If you're doing a blood work. Now,
we are only managing with LH, or you do also ultrasound?
No, we are doing ultrasound, absolutely. But at the same time, if there are patients going through a natural cycle, then we would ask them also to use the ovulation kit for an LH. They get an idea when the LH is going up, but usually with the ovulation kit, you come to know only when the LH has already arisen. You don't know when it's going to start. So in short, when you are examining a patient with ultrasound, and you're looking at the triple lying layer, and you're looking at the appearance of the endometrium, there is also a possibility of looking at the follicle. Now, when you see that the LH is rising, when you're doing a serum level of LH, I like to do a serum level. I prefer that. And when we see the follicle sort of getting there's a typical appearance which you will see when it's getting ready to rupture. And that's the time probably we would think about expecting the ovulation to happen. Once ovulation happens, then of course we start the timing of the embryo transfer.
And so you don't give HCG. This is just a natural.
That is in the modified natural cycle.
Correct.
If we were talking about natural cycle.
Yes. I
prefer a modified natural cycle rather than a regular natural cycle.
Okay. because this is very, as we say, weekend
Yeah.
comes all the time. Even the follicle becomes 18, 19, it is on
Correct.
Saturday or Sunday. Then who's going to
Yes.
do LH search for them?
Absolutely. I totally agree with you.
So, and if you are transferring one frozen embryo and you have 5 frozen embryos with you, how many cycles you are going to waste? So it becomes
Well,
a little problem.
natural cycle, somehow it's not very practical, to be honest.
Correct.
I think there's another question to Dr. Duru. You did mention about GnRH agonist 1 dose. In fact, in your slide, it said that 3 days after embryo transfer. But do you think is after 7 days of embryo transfer is better than day 3?
No, this was
one dose of GnRH.
Yeah, this was the study which was reported, which I was talking about, as a matter of fact, that they were giving it on the 3rd day after the embryo transfer. Now, probably the principle or the rationale behind it would be that if you have used HCG and you have triggered ovulation and you have the GnRH agonist we were talking about in the freeze-all cycle, right?
Yes.
Right. So in that case, because there is a deficiency of LH, there is a suppression of LH. In those cases, if you're going to give a GnRH agonist, you may stimulate the pituitary to release LH, and that could help with the supplementation of progesterone. Probably that is the rationale which has been used, and the GnRH agonist has been given accordingly. Because when we use HCG as a trigger, we know that the HCG in circulation reaches, may last for about 7 to 8 days after the injection of HCG. And then the trophoblast starts taking over by the secretion of HCG. But the problem is that there is a phase wherein the progesterone is dropping and the HCG is rising. So there's not enough progesterone in circulation sometimes to help with the implantation process. I mean, to make it, sort of better. So this is the reason probably why they find that by giving a GnRH agonist, you're able to improve the pregnancy rates.
Yeah, one more question to you. I think if the progesterone is about 100, too much of progesterone, it's bad or really bad, isn't it?
No, at least it shows that the results, the studies are showing that the progesterone which goes beyond a certain limit is known to reduce the amount. Found in these studies is they say that 10 nanograms, for an induced cycle, 30 to 50 nanograms per ml is the mid-luteal progesterone you get when there are many follicles growing, right? But in a one follicle cycle, like a single ovulation cycle, a 10 nanogram value is good enough. But some of these studies have shown that, even if you get 10 nanogram plus, you're getting a good pregnancy rate. But in our own data, what we found is that we compared the progesterone which we do on the day of HCG. The first HCG when we also do a progesterone. At that time, we find that as the progesterone is rising and it reaches a phase of about more than 50, between 30 to 50, okay? That is the time we find we get the best pregnancy rates. So this is, of course, different from what study which I discussed. But what studies are showing that anything above 10 is good enough for you to get a successful pregnancy.
Yeah, just to supplement.
But if the progesterone is high, as you suggested, they are showing that the pregnancy rates drop.
Yeah, the second same supplement question to you, Duru. Do you do just on the day of little before, when are we doing the estimation of progesterone? Is the question. Which day after embryo transfer, or is it 2 days, 3 days, 7 days?
Most of the studies, we do it in mid-luteal phase. That is, you're talking about, when you're doing the embryo transfer.
Yeah, one question to Dr. Nayana Patel. One of the delegates asking you, a case of tuberculosis of the uterus, all additional lysis done in the uterus, and then no response to the medication. How do you manage that particular case to get the endometrium?
Well, the endometrium in the tuberculosis patient is really, really bad. But what study I said, first of all, we'll try number of times hysteroscopy, subendometrial PRP, or bone marrow-derived stem cell concentrate. And out of the 3 patients that have conceived, 2 were tuberculosis patients that were very thin endometrium, where we have taken the bone marrow-derived stem cell concentrate without treating it and just separating the cells in hour and a half. We took them into the cath lab, and the same technique which Carlos Simon had used, we went from the femoral artery to the opposite internal iliac, go to the uterine spiral arterioles, and they say there are small places of isolated basal endometrium lying there. And that is where there will be homing in of the stem cells, and that will stimulate the growth. And literally these 3 patients will have for initial 3 months much more bleeding menstrual flow than before. And these 2 patients of tuberculosis with bad Asherman have conceived. One has delivered and one is having twins right now.
So when you mean by subendometrial installation, it is going...
Not subendometrial. We do hysteroscopy subendometrially, we do PRP, we cut the adhesions, and then into the cath lab. I think it's a very, very aggressive treatment, but when there is a thin endometrium not responding to anything, you try estradiol, you try sildenafil, you try hysteroscopic subendometrial PRP, GCSF, nothing works. Then we take them into the cath lab. If the patient has to stay in the ICU for 24 hours, and both the femoral arteries we have to go, and we have, to our surprise, out of the 7 cases, 1 case had totally stenosis of the hypogastric artery, absent uterine artery in 1 case. So these findings are there, and tuberculosis patients, I think, will definitely benefit from this treatment.
There is one more question. Dr. Sarah, you are here again. Can you hear us? Okay. Do you do hatching for every time frozen embryo is being transferred?
No, of course not, definitely not. Like I say, we tend to let nature do things on her own as much as possible. So hatching is done for some particular reasons, but definitely not for every case. It's just something extremely rare to be done in Finland to such extent that
She has a problem.
Madam, we just have a minute more. Dr. Sadhana, I would like to conclude.
Okay.
Wonderful session. I request Dr. Sadhana Desai to continue.
Okay. I think there is a full justice done by all the 3 speakers on the difficult subject, because we all do embryo transfers. We were most of the time doing embryo transfer with hormone replacement therapy. It is lately that the papers are coming and we are finding that maybe it is better to do it in a natural cycle. But the natural cycle is difficult to monitor, and HRT cycle still has a place till we find an easier way to do the hormone replacement, easier way to monitor the ovulation in the natural cycle. As many a times we do come across that patient's endometrium becomes very nice and lush at the time of ovum pickup. But when we do the embryo transfer, with frozen embryo transfer, the endometrium doesn't respond well. And some of the patients with oral estrogen tablets don't do so well, and they do require intradermal estrogen therapy. And I think there should be some way people should, as we are doing intravaginal progesterone, and we don't give oral progesterone so much because we are worried that it may not get absorbed. Similarly, we should have some trial where we should compare the oral estrogen with the transdermal estrogen. This is what my suggestion is. Dr. Pratap, you want to say anything?
I just want to thank wonderful speakers for all the excellent presentation. We enjoyed it thoroughly, and I'm sure all the delegates also done it.
Said Dr. Duru, I want to compliment you. In discussing at length frozen embryo transfers and the freeze-all technology, because I think this is the in thing, and all youngsters are all keen to transfer every ovum. They want to freeze everything, and the patients come and demand that you don't transfer in this cycle, please transfer it in the next cycle.
Yeah, so that's true.
I'm glad that I introduced Dr. Duru, the mitochondria of PCOS. You really deserve a much bigger applause from all of you.
Thank you. But the main thing is, in PCOS, we really need that freezing of embryos necessary almost because of the hyperstimulation which occurs. And I think, being the PCOS Society of India, we were keen to focus on that area as to what's happening to the embryos which we are freezing. There are so many difficulties we face, and I think that was what stimulated me to think about it. And thank you very much for all your warm words.
Thank you, Sarah. Thank you.